Okay, so for the filtration, it's best to understand this image first. Basically, this is an afferent arteriole that starts with A, which means that arteriole that is going into the corpuscle and surrounded by the Bowman space, or actually the Bowman capsule. It's this big yellow thing. And then, of course, this let me delete all of this. And then this afferent arteriole, as it flows, it has a blood flowing inside that corpuscle. It will go out, but when it goes out as an efferent arteriole, and then it moves next to the proximal convoluted tubule and the rest of the renal tubule. So what is happening here is that the blood within here needs to be filtered, like the solutes within this blood needs to be filtered and then go outside as urine. So the filtration takes place over here. The particles move through these parts of barriers. This is the first part, so this is the endothelial cells, and right next to it is the other endothelial cells. So blood moves within these fenestrations, and it will encounter this pink line over here. This is the basement membrane, this is the second barrier, and then it will meet the third barrier over here, and it's the podocytes, and then it should flow within the fenestrations between each podocyte and the other into the Bowman space, and then the Bowman space collects the filtrates and then goes as a proximal convoluted tubule, and then loop of Henle over here, and then ending as ureters, and then to the outside of the body. And now blood is, urine is excreted, and urine is containing all the filtered materials. So what is happening within these stuff. Actually, let's not talk about the pressures now first. We have the juxtaglomerular cells over here. So these are the juxtaglomerular cells. It's between the afferent arteriole, the incoming arteriole, and the distal renal tubule. Is the last part of the renal tubule. So it's all this tubule is going all this way and then ending up as distal renal tubule that has specialized cells called the macula densa. They do sense the NaCl concentration within the urine, and depending on that, they do increase its reabsorption or not. For the juxtaglomerular cells, they're over here, and they're also modified cells that are responsible for secreting renin in response to different stimuli. So what we have mainly is that, okay, let's now read. The filtration fraction is an equation of the glomerular filtration rate divided by or over actually the renal plasma flow. We already know that the normal filtration fraction is 20%. Another equation is the filtered load equals the GFR by the plasma concentration of a specific material. So the GFR can be estimated with creatinine. We know that the GFR completely or totally equals the clearance of inulin, but we don't do that. We don't use inulin to calculate the GFR in clinical settings. We use the creatinine because it's more sensitive, even though it's just slightly, as we said over here, overestimates, just a little bit overestimates. We said that somewhere. Okay, there you go. It slightly overestimates the GFR, but we still use it in clinical settings because it's more sensitive to changes in renal function than inulin. So for the renal plasma flow, so for the GFR, it's best to use creatinine, while for the renal plasma flow, it's best to use the para-aminohydric acid clearance. Here we're gonna have two main effectors that do affect the GFR, the filtration rate, or the filtration fraction. First one is a prostaglandin, which dilates afferent arteriole. So we know that the afferent arteriole is this arteriole over here that's supposed to bring blood into the corpuscle, into the glomerulus. And what happens here when we have prostaglandin, it dilates these vessels, making it larger or wider, so it's allowing for more blood to flow into the corpuscle. And because more blood is going into the corpuscle means more material being filtered into the bone mass space. So now we have an increase in the GFR. And at the same time, yeah, this is what it says. Person dilates afferent arteriole, and while the angiotensin, that's the second effect, is that it constricts efferent arteriole. So if we take a look at the angiotensin 2, what it does is that it constricts efferent arteriole. So it's the arteriole that is going outside the glomerulus. So instead of being this wide when there is a higher level of angiotensin, it will constrict to this side, okay? Which means now it's harder for the blood to flow through it because you have a lot of blood. So all of the blood that was here is supposed to go out and flow through this teeny tiny new vasoconstricted vessel, um, which means the blood has to stay over here for a longer period, which means there is much more material being filtered out into the pulmonary space. Um, yeah, so if we take a look at the image over here again, if we talk independently again about the prostaglandin, they preferentially, as we said, they dilate the afferent arteriole, so they increase the renal plasma flow, and then they increase the GFR. So for the filtration fraction, we know it's an equation. Filtration fraction equals the GFR over the renal plasma flow, and in our case, the GFR has increased, and then the renal plasma flow has also increased. So actually, increase it's another increase. So there is no change. Okay, so in the filtration fraction. So there is no change in the filtration fraction because both the renal blood flow and the GFR has increased. While when we talk about the angiotensin, it will constrict efferent arteriole, so now the renal plasma flow is reduced. The reason why is that happening, because now we know, because of this new vasoconstriction over here. Okay, so there you go. The vessel constricts due to the angiotensin 2, so now it's smaller, now it's more difficult for this blood to flow through it, so now blood needs to back up and stay here for a little bit longer, and then it gets more filtered, so it increases the GFR, and this is what it says. But then the blood is still coming fine, like coming into the corpuscle still fine, because we have not changed. The angiotensin does not affect the efferent arteriole. So what means is that since it's harder for the blood now to leave, then the blood backs all the way up to the beginning, and now more blood coming into the glomerulus is having a hard time reaching the center of the glomerulus, because there is a lot of blood that is already there, a lot of blood that cannot leave. So that's why it's harder for the blood to come in more into this corpuscle, because it still has a lot of blood that hasn't left yet. So that's why we have the decreased renal plasma flow, and because the filtration fraction is an equation of GFR over the renal plasma flow, and this is decreased while the GFR is increased. So by math, we know that the filtration fraction is now increased because the GFR has increased and the renal plasma flow has decreased. So that's for image. Okay, one important thing to know, a very important thing to know, is that both of these spaces, I mean the vessel, the space within the vessel and the space within the Bowman capsule or Bowman space, both of these has two, each one of those actually, each one of those has two different types of pressures, okay? So within the vessel, the blood has something called hydrostatic pressure. So the hydrostatic pressure of the glomerulus, which means the hydrostatic pressure of the blood vessel that is called the glomerulus, and it is the pressure that is pushing the solutes or infiltrate or filtrates or whatever material that this blood has into the Bowman capsule. So it's pushing to the outside of the glomerulus. It's pushing to the outside of the glomerulus. This is what's called hydrostatic pressure. So it's pushing all of its contents or whatever it can to the outside of it. While this is type 1 of the pressures that is inside this glomerulus, inside this blood vessel. There's another type of a pressure also within the glomerulus, within this blood vessel, but it's called oncotic. So oncotic is the pressure that pulls things into the vessel, okay? So it's also within the vessel, but actually what it's doing is that it's pulling stuff into the vessel, okay? That's is called oncotic. The same thing applies for the Bowman space. So the Bowman space by itself has something called the hydrostatic pressure, which means it pushes stuff from within the Bowman space into the vessel. So it pushes things to the outside of the Bowman's space, and this is called the hydrostatic pressure. And also that's only one of the two different pressures that Bowman space has. So guess what's the other one? It's an oncotic pressure. So oncotic pressure is just, as we talked about, is the pressure that pulls things into the Bowman space, okay? So it pushes things or actually pulls things or take things from the outside into the Bowman space. So basically what we're trying to say here is that it's a battle between two pressures, actually four pressures. Each two of those are going within the same side, within the same direction. So the net filtration, like the amount of filtered stuff, filtered solutes, is determined by this pressure difference. So we are putting the hydrostatic pressure of the glomerulus plus the oncotic pressure of the Bowman capsule, and this is it. So the pressures that are going on the same side, and then minus the pressures that are going on the contrary side, okay? So yeah, the result of this equation is what determines how much of a solute is going to be filtered and is going to swim in the urine and get excreted into the body. Okay, so now we know, because we said excreted, so we know that excreted means that stuff are going to be expelled to the outside of the body, while two other terms here is that reabsorption is when we decide that there are some things in the urine over here, some things that has filtered, okay, but we still need them. So we decide to take them back into the blood vessel. So back into the efferent arteriole that is going, that is now being called the peritubular capillary. So we decide that we want them back. We don't want to leave them, just like amino acids, just like glucose, things that we need. And there are some few stuff that we don't need anymore, like they are already filtered, but still we want to excrete more of those into the urine. So this is when the peritubular capillary decides that it's time for it to extra clear itself by secreting its material into the urine to be excreted, and that's what's called secretion. And that's it for this image. Now, if we take a look at the changes in the glomerular dynamics, okay, so what we have, if we have afferent, okay, A, so that's the vessel going into the corpuscle, afferent arteriole constriction, then we have a decrease in the glomerular filtration rate, and then a decrease in the renal plasma flow. Okay, so if we take a look over here, let me delete all of this, okay? So this afferent arteriole now, let's suppose that is being constricted, okay? So now it's decreasing in size, it's being constricted, okay? So now it's smaller in size, has a smaller radius, which means blood, this is blood in red color, has a harder time going into it. So now we only have less blood going into the glomerulus, which means less blood being filtered, okay? Because it's hard for the blood to go inside this vessel. So for the GFR is decreased because it's less blood over here being filtered, and then renal plasma flow, of course, because the blood vessel is constricted, so it's hard for the blood to move through, and now the renal plasma flow is also less. But for the filtration fraction, there's actually no change because it's GFR over renal plasma flow, okay? And both of the GFR and the renal plasma flow are decreased. So a decrease with a decrease actually doesn't make any difference. So there is no change in the filtration fraction. If we say that, or if we suppose that the efferent arteriole this time gets constricted, so this is the efferent arteriole, and this is its normal size, but then let's suppose it gets constricted, so now it becomes smaller in size, which means blood has a harder time really going outside of the glomerulus. So it's within the glomerulus flowing normally fine, but it's really hard for it to move to the outside of the glomerulus, which means the blood has to stay within the glomerulus for a longer period, okay? It's not easy for the blood to move out of the glomerulus, which means because it stays here a longer period, then there's of course more filtration, more time to filtrate stuff from within the glomerulus into the Bowman space, okay? And also we said that so that's why the GFR increases, because we have increased the amount of time the blood is being over here filtrating, while the renal plasma flow gets decreased because, as we said, blood stays here a really long time, so it's even harder now for the blood to come in because it will already meet with this pre-existing blood. So we have less blood coming in, okay? So that's the decreased renal plasma flow, and according to this equation, the filtration fraction is going to be increased. This is just math, okay? So the other possibility is an increase in a plasma protein concentration. So this one is nice because we need to imagine a few particles. These are the few particles within the blood are proteins, okay? So if we have more proteins within the blood, more plasma proteins, we know that proteins do increase one of those pressures. They do increase the oncotic pressure, which means if we have more proteins, we will have more oncotic pressure that is pulling things from the outside to the inside, okay? So now that we're having more proteins, which means the glomerulus or the blood vessel is having more oncotic pressure, so it's pulling things even harder, and this will change this equation because now the oncotic pressure of the glomerulus is increased. So the net filtration changes. That means it's harder for the stuff to move out, okay? They are now being faced with a stronger force that is pulling stuff in. So that's why the GFR is reduced, the glomerular filtration rate is reduced, while the renal plasma flow doesn't change because we haven't changed anything with the blood coming in. We only know now that it contains more proteins, so we didn't change the flow at all. For the filtration fraction, according to this equation, now because we said the GFR is reduced, so the filtration fraction is reduced, of course. If we do the contrary, if this blood has less plasma protein concentration, so now all these blue particles has much less number, okay? So this is a much less number over here, which means that we are decreasing the oncotic pressure of the glomerulus, which means we are decreasing the force that is pulling things to the inside, okay? which means we are also changing some factors within this equation. So now we are affecting the net filtration pressure. So the GFR in this case increases, and then the renal plasma flow as well didn't change because we haven't changed anything. We only changed the concentration of the proteins within the blood. For the GFR, according to the math of this equation, then it will be increased. And the other possibility is the constriction of ureter. So we know that this proximal convolute tubule is going as loop of Henle, and then distal convolute tubule, collecting ducts, ending up being a ureter, okay? And ureter expels things or urine to the outside of the body. So let's just suppose that we have a constriction in the ureter or a blockage over here that is not allowing this urine to be excreted. It's blocked or constricted at least, okay? Let's say it's constricted. So now it's harder for this urine to flow through a constricted ureter. So which is definitely not good. It means urine will back up this way, and that is not normal. That is not good, okay? But what can we do? The outside is either obstructed or constricted. So the urine flows back, and when it flows back, then of course it will increase the hydrostatic pressure of the Bowman's capsule, which means also a difference within these pressures of these equations that will make it harder for the blood to filtrate its content, okay? Now, it's really hard for the blood to push its content into the Bowman's space, okay? That's hard, 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 again hard because the urine is back flowing into the corpuscle, into the Bowman's space. That's why the GFR is reduced. The renal plasma flow didn't change. We didn't do anything over here, okay? We only changed the outlets. And according to the math, for the filtration fraction is decreased. And the last option that we have, or possibility, that is dehydration. We know in dehydration, there is less circulating volume, which means the amount of blood that goes to the lungs, to the heart, to the liver is just less. So there is less systematic blood flow. So the amount of blood that goes into the vessel, afferent vessel, into the glomerulus is less than expected. And if it's less than expected, then of course there will be less filtration, not as much. So the GFR is reduced while the renal plasma flow, this is our main issue, it's overly reduced because we have only small amount of blood flowing in, and then according to the math, the filtration fraction is increased. And that's it for the filtration. Let's go ahead and see over here what we have. Okay, so if I delete all of this, actually no, I want this one. Yeah, let me delete this. Okay. Where was I? Yep. There we go. So for the calculation of reabsorption and secretion rate, we have an equation that says that the filtered load equals the GFR by the plasma concentration of a material that is X. Let's suppose we're talking about X material, okay? And then the excretion rate usually equals the flow of the urine with the multiplied by um, um, the urine concentration of the material X as well. We also have the reabsorption rate and secretion rate. So the reabsorption rate, if we take a look at this image again, it's filtered minus excreted. So we're talking about this part, okay? This is excreted material and this is filtered material. And we were talking about the reabsorption rate. So that is the filtered minus the excreted. So the reabsorption, like how much are we reabsorbing of stuff from the urine in the blood, it basically equals how much we have filtered from the glomerulus minus, I mean, except for how much we excrete. So the difference is the amount of reabsorption, and then the amount of secretion is basically the excreted minus the filtered. So it's totally different. I mean, totally the opposite, because this is secretion. This is the amount of stuff we are secreting into the urine. So it equals the secreted material minus the filtered material, and that tells us how much we have secreted. So now what we're going to do is only replace the equations that we know. So if we're talking about the sodium, okay, we, oh, okay. So if we're talking about the sodium, Fe of a sodium means the fractional excretion of sodium, okay? And it equals that the amount of sodium that is being excreted over the amount of sodium that is being filtered. And we know that we are going to change each one of those words with its equation. So for the excretion equation, it's over here. So it's the flow of the urine multiplied by the amount of sodium within that urine, okay, over the other equation of the filtration. So this is the equation of the filtration. It's the GFR by the plasma concentration of sodium, because we're only talking about sodium. What we can do is that we can change this GFR with its old equation that we have known before, okay? So this equals GFR. Remember, we already talked about previous equation. So this was the equation of GFR, okay? We have only replaced it by its name over here. So this became this. So it's only a matter of replacing the words by its equation. So now over here we have purely math, okay? We're taking this out, and the whole thing results as this equation. So that's the end result, okay? And of course, we are using creatinine over here because we know that the GFR in the clinical settings is measured by the creatinine, okay? So yeah, basically just a matter of math. For the glucose clearance, the glucose at our normal plasma levels range between 60 and 120. Okay, so this is just like checking the random blood sugar of a person. And in normal people, normal adult person, it's just the normal range of glucose in the plasma or the blood is between 60 to 120. And because glucose is useful and important for the body, we do completely reabsorb it in the proximal convoluted tubule by a channel called, or actually a cotransporter called sodium glucose cotransporter. So if we take a look over here, so we are filtering some of the glucose particles, okay, and they are moving over here within the urine, but then we remember that we need all of that glucose back in the blood. So what we do is that we completely reabsorb it into the blood by the proximal in the proximal convoluted tubule. So we don't excrete glucose at all under normal conditions, of course, except for pregnancy, and we'll talk about that now. So what it says, and the way we do it, we have some channels over here in the wall over here. They're called sodium glucose co-transporter. So they transport sodium and glucose at the same time. In adults, at plasma glucose of 200. Okay, so when the plasma glucose is normal, that is 60 to 120, we are definitely absorbing all of the glucose that is being filtered. So if you check the urine, you don't see any glucose at all, okay? But then let's say this person has now pre-diabetic or started to become diabetic or has any problem that is causing its blood sugar to rise. So now what we see in his blood is that he has a plasma level of glucose of nearly 200. And that means now we are going to start to see glucose in the urine, glucose urea. So that's the threshold. So at number 200 of glucose concentration within the blood, that's when we start to see glucose urea. That's when we start to see some glucose being excreted in the urine. And then at the rate, let's say this person now is actually really diabetic or really has some other issue that is causing its blood sugar to be raised until it gets 375. That means all of the transporters that we talked about, they are sodium glucose co-transporter. They're responsible for transporting glucose back into the blood. At this number 375, all of those are going to be saturated, so they are unable to move any more glucose particles into the blood. And because they cannot move these glucose particles into the blood, that means these glucose particles are going only one direction. They cannot pass into the blood, so they will be excreted in the urine. That's why when we check the urine now, we will see that we start to have glucose urea. So we have urine filled with glucose now. Yeah, so at the rate of 375, all the transporters are fully saturated. That's why we call them Tmax. This is, of course, under abnormal conditions. When the person starts to have 200, we start to have the glucose urea. But when it comes to a number that is 375 of glucose in the plasma, then all the transporters are going to be saturated. But that's for the abnormal conditions. If we have a pregnancy, which is a normal condition, normal physical condition, the GFR for pregnant women increases its filtration of all substances. So everything is extra filtered within the glomerulus over here. So everything is extra filtered, extra filtered, extra filtered. So it makes sense to see some glucose in the urine, like a lot of glucose in the urine, but that doesn't have to have a problem with this transporter that was over here. It's just a normal physiological function. Pregnant women is filtrating too much glucose, so we see it in the urine, but even with normal plasma glucose levels. Okay, so the transporter that we talked about, that is called sodium glucose co-transport 2, sodium glucose transporter 2, has some drug inhibitors that we can use, and these are the drugs that ends up with the word flozine. They result in a glucosuria at a plasma concentration of less than 200. So if a patient is using some of these inhibitors, they inhibit the transporter that is okay. So this is the transporter that needs to take glucose and sodium into the blood. So if we inhibit this transporter, that means we will see more glucose in the urine, even if the plasma concentration of a glucose less than 200. The glucose urea is an important clinical clue to diabetes mellitus. Of course, we know it will help us know if someone has start to have diabetes if we see it's a glucose in the urine, which under normal conditions we should not see unless it's a pregnant woman. That's why in pregnancy, in order to check if the female has a diabetes, then we need to check the blood sugar, her blood glucose, not the urine sample. That's not for pregnancy. So we have something called the supply phenomena. that's when the Tmax, so we get all saturated channels for glucose, is reached gradually rather than sharply due to heterogeneity of the nephrons. So in one kidney, so we know that this is a kidney and it has so many nephrons, okay? And so many glomeruluses, if that's a word. So each one of those has its own amount of these transporters, of sodium glucose transporters. So if one of those gets saturated, like the channels within this glomerulus get saturated, doesn't necessarily mean that all the channels within this glomerulus will also be saturated, because the amount of channels in this glomerulus is different from the amount of the channels in this glomerulus. So that's how we get this supply phenomena. And if we take a look at this diagram over here, the x-axis is talking about the plasma glucose. So how much of a glucose in the blood? Okay, and then over here in the y-axis we have the glucose transport. So these are the channels that are called sodium glucose co-transport. Okay, so what we see over here is that under normal conditions, when the patient's glucose level is, we said, between 60 or 120, so it's normal, not 200 yet, it's just normal. We see that the excretion curve doesn't go up, it's just zero, because under normal conditions, when we have normal plasma glucose level, all of the glucose is being reabsorbed. So we are not excreting anything because that's normal conditions. This patient is not diabetic. This patient doesn't have any issue with dysregulation of a plasma glucose. So I mean, its pancreas and its insulin is keeping the glucose within normal limits. So we are not excreting anything. This patient is not excreting any glucose, and here just reabsorbing the glucose over here. So the red curve is about reabsorption, okay? So it's fine. It's just reabsorbing all of the glucose, and all of the glucose that is being filtered. We don't have any issue with filtration. The glucose is being filtered, but at the same time, it's being reabsorbed, okay? But then this patient started to have a problem, and this problem leads to an increase in his plasma glucose. So now we have plasma glucose of 200. That's when we see a rise in the excretion of glucose. That's when we start to see some glucose in the urine of this patient, okay? And then this gets worse when the plasma glucose level increases. So this patient has a worse diabetes. So now he has a plasma glucose level of 400 or 600. That means we are going to see much more glucose being excreted in the urine, which is abnormal. And that means until we get to a plasma glucose levels of 375, that means all of the transporters are fully saturated now. So we lose our capability of reabsorption. So this is what we see over here. So we were reabsorbing stuff really normally until we get to a number that we cannot reabsorb anymore, but it's not sharp increase, it's a supply phenomenon. That's why we call it supply. So it's a gradual increase. This gradual increase in this curve means we are gradually losing our ability to reabsorb the filtered glucose, okay? And that's it. So this is the Tmax. This is where all of these transporters are saturated and they cannot transport any more glucose into the blood. That's when the plasma glucose level usually gets 375. And that's it.